Now we're going to discuss pacing, and we'd also include concepts of conduction system pacing, biventricular pacing, CRT, and right-sided pacing. Now, animal models have been created for heart failure wherein constant pacing causes cardiomyopathy. This phenomenon in human beings is called as pacemaker-induced cardiomyopathy, which is defined as a decline in EF of 10% or greater with heart failure symptoms and is attributed to a high burden of RV pacing. Its incidence ranges from 6% to 40% and probably an average of about 10 to 12%. There's a pacing threshold above which the risk goes up. If someone is paced more than 20 to 40% of the time, then the risk of pacemaker-induced cardiomyopathy goes up. Pacemaker-induced cardiomyopathy has been shown to be reversible when you upgrade the device to physiological pacing. So, in right-sided pacing, there is dyssynchrony, and when you remove the dyssynchrony, then cause synchronous pacing, then the cardiomyopathy resolves. So, cardiac resynchronization therapy is where you pace the right side via the endocardium, the left side via the epicardium, and resynchronize the LV. Conduction system pacing is an emerging approach where you pace either the his bundle or the left bundle. So again, cardiac resynchronization therapy, one lead is in the RV, the other lead is through the coronary sinus, anterior coronary vein, and right next to the LAD in the venous system. And thus we get LV epicardial pacing and endocardial pacing on the RV side. The left ventricle is paced synchronously. In his bundle pacing, the pacing occurs at the level of the his bundle, and direct stimulation of the his bundle causes selective his only or non-selective his plus local myocardium. Left bundle pacing, the pacing occurs at a lower level, and it's intended to engage a part of the left bundle or its fascicles. So, when you consider pacemakers, is it primarily for bradycardia or for heart failure? What is the patient's heart function at baseline? And the electrical substrate. What is the QRS duration and morphology? Left bundle or non-left bundle? Therefore, if a patient has a permanent pacemaker indication and you expect the RV pacing to be greater than 20 to 40%, if the LVEF is 35 to 50%, then you should consider CRT, his bundle, or left bundle branch block pacing. On the other hand, if the EF is normal, then it may be reasonable to treat patients with CRT, his bundle, or left bundle branch block, but it's not mandatory. The 2023 guideline expands the consideration of physiological pacing to patients with normal EF who may require substantial ventricular pacing, aiming to prevent pacemaker-induced cardiomyopathy before it develops. So, for patients with less than substantial pacing, less than 20 to 40% anticipated pacing needs, if the EF is greater than 35%, it is reasonable to choose a traditional RV lead system. On the other hand, if they have a normal EF and there is less than 20 to 40% pacing, then a CRT device is contraindicated, there is no benefit. Whereas a left bundle branch block lead, left bundle branch pacing lead may be considered as an alternative. This guideline provides a new specific recommendation for left bundle branch block pacing as an alternative to RV pacing in patients with normal EF and the low pacing burden. So, cornerstone of heart failure therapy is cardiac resynchronization therapy for heart failure, reduced ejection fraction with left bundle branch block and a wide QRS. So EF less than 35%, left bundle branch block morphology, QRS more than 150 milliseconds. The recommendation is cardiac resynchronization therapy. Now, in women with a narrower QRS, 120 to 150 milliseconds, it may be reasonable to proceed with cardiac resynchronization therapy, as in the presence of a smaller heart, even at a lesser QRS width, cardiac resynchronization therapy might be beneficial. So, if the patient is a candidate for CRT, EF is less than equal to 35%, left bundle branch block morphology, first line strategy is cardiac resynchronization therapy. Alternative strategy is conductive system pacing. Or if CRT failed because you're not able to pace the left sided lead, then you may consider conduction system pacing as a bailout. Now, for those with mild LV dysfunction and non-left bundle branch block morphology, if you have an EF 35 to 50%, you're in sinus rhythm, left bundle branch block, QRS more than 150, NYH 2 to 3 or 4, clear-cut CRT recommendation. On the other hand, non-left bundle branch block morphology, EF less than equal to 35%, QRS more than 150, CRT with bi-V pacing can be useful. Now, if someone develops pacemaker-induced cardiomyopathy because they had a right-sided pacer lead, then upgrading the device to a CRT device can reverse the LV dysfunction. First recommendation would be to upgrade to CRT. Recommendation 2 would be to consider conduction system pacing. Okay, during implantation for CRT, you should use quadripolar LV leads. In conduction system pacing, a 12 lead EKG is useful to confirm the conduction system capture. If there's slurring noted, that would suggest that it is not conduction system pacing. Post-implantation, you should consider echocardiogram 3 to 12 months post-implant to assess for reverse remodeling. Remote monitoring is highly beneficial. And for patients with unfavorable response, consider reversible causes. For example, is the patient pacing adequately? If they're not pacing adequately, then they would not get the benefit. Now, this is a multidisciplinary approach between primary care, electrophysiology, and the heart failure doctor. For some unmet needs should be considered. Should we do conduction system pacing versus CRT? Large randomized trials are needed. Long-term conduction system pacing data is needed. How to predict response? We need to develop better tools such as advanced EKG, perhaps use of AI to predict beneficial response. These are new things that need to be considered. Finally, cost effectiveness analysis would also be needed. It should also be noted that not everybody who gets a right-sided pacemaker automatically develops pacemaker-induced cardiomyopathy. Thank you for listening. More to follow.